Welcome everybody to the Advancing American Kidney Health Through Optimal Medication Management presentation. I'm really excited to talk to all of you today because I feel this initiative is really focused, particularly for ambulatory care pharmacists. And there's opportunities out there today in terms of ambulatory pharmacists becoming engaged and working with nephrologists and other providers in the care of kidney disease. So today I'm Wendy St. Peter. I'm a professor in the College of Pharmacy, University of Minnesota, and I'll be giving a presentation today. I've got three co-hosts today, Dr. Ela Harris, Dr. Chrystian Pereira, and Dr. Ann Philbrick, all good colleagues of mine from the College of Pharmacy. They're going to be monitoring the chat for me during the presentation and making sure that if you have any questions that they will be happy to break in so we could get your questions answered as they go along. We will have a discussion period at the end as well. And so I'm going to just get going. So basically our outline for today is to go through a background and the goals of the Advancing American Kidney Health Initiative. I'm going to talk to you today about new value-based kidney care models, which I think give an opportunity for pharmacists to get involved in the care of these patients. It's also opportunities for nephrology practices, and I'll discuss why as we go through this. And at the very end, I'm going to talk about our own initiative, which is Advancing American Kidney Health Through Optimal Medication Management, and how you can get involved. So about kidney disease, I know that many of you in your practices see patients with kidney disease, but up until last year, kidney diseases have really lacked appropriate recognition and urgency. We've got over 37 million people in the US that have some stage of chronic kidney disease or are on dialysis or have a kidney transplant. And it's costing the healthcare system a ton of money. For Medicare alone, is over $114 billion a year. And if you look at it just strictly from the standpoint of patients who reach end-stage renal disease, Medicare, those patients represent about 1% of the Medicare budget, but the spending reaches 7% of the Medicare budget. So these patients are expensive, and both Medicare and as well as private healthcare systems are recognizing that we need to do something about reducing progression to kidney disease. So healthcare, kidney healthcare became a national priority in 2019 with an executive order on advancing American kidney health. So this has been 50 years after the government declared that every American that needs it should receive dialysis, and it was incorporated into the Social Security Act to have Medicare pay for dialysis and transplant. Now, 50 years later, we've got a new framework for winning a war on kidney diseases. And there's some bold goals with this initiative. And that is decreasing the number of Americans developing kidney disease by 25% by 2030. And an even bigger goal is aiming for 80% of new kidney failure patients receiving either a transplant or going to home dialysis, which is a huge shift given that the vast majority of our dialysis patients are located in hemodialysis centers. And how does CMS propose to do this? Well, through new value-based payment models. So of course, I know that you all recognize the fact that value-based payment models really incent clinicians to provide high-value services that are focused on quality, patient healthcare outcomes, and also quality and cost containment. So how do these models propose to do it in the kidney disease space? Well, they're investing in earlier intervention. So in CKD stage 4 and 5 patients. So CKD4 starts at an eGFR or GFR of 30 mils per minute. So basically what Medicare wants to do is shift dollars that are currently being used in the dialysis and transplant patients to upstream to earlier stages of chronic kidney disease. They also reward increased utilization of home dialysis. I think it's something that pharmacists can get involved in. A lot more patients getting their care at home. Pharmacists can get into their home. And then there's rewards and bonuses for transplantation and keeping the transplanted kidney healthy and the patient alive for at least 3 years after their transplant. So these new models of care are known as the kidney care choices models. These are voluntary models, and they focus on chronic kidney disease stage 4 and 5 all the way through dialysis and transplant. Again, shifting Medicare dollars from end-stage kidney disease to earlier stage kidney disease. Or no, and that would be the best part, of course. So what these models do is they are incenting nephrologists, nephrology practices, along with others like transplant centers and transplant surgeons and dialysis providers to participate in these models. So nephrology practices with their other partners submitted 200 plus applications. And then CMS came back and looked at all the patients that were attributable to their practices and made sure that they had enough, CKD stage 4 and 5, as well as dialysis and transplant patients to be able to actually be a part of this model. The model implementation actually started last month in October 2020. But the payment piece of it, the cost sharing and incentives actually go into effect in April 2021. So essentially what it allows is these nephrology practices to get their partners and to gear up and see how it all works before the payment pieces, both the penalties and rewards kick in. The demonstration ends on December 2023. So again, these payment models are value-based payment models. They incent earlier intervention in CKD stage 4 and 5, and of course incent home dialysis as well as kidney transplantation. Now, some of the proposed performance metrics for this model are things that I think pharmacists can impact. Things like patient activation. So the PAM score right now is being proposed to evaluate patients. And one of the questions on the PAM score directly relates to whether patients understand their medications and how to use them. But I would say that with our CMM practices and getting patients activated in their own self-care, that we could actually affect more and positively more of those questions on that survey. There's also another metric on depression remission. And of course, depression is being treated in primary care practices. So this is another area I think that we can do. Optimal end-stage renal disease start. So this is really important in terms of good pharmacy care. If we are doing a good job in treating CKD stage 4 and 5 and getting nephrologists involved in those care, we're going to have less patients crashing onto dialysis where they're very expensive because they're hospitalized for long periods of time oftentimes. They get infections and things because we have to put catheters in it instead of having like a fistula or graft. And so that's something we can get involved in. And surely with all those impacts that we can have, we can reduce and help reduce hospitalization costs and total per capita costs, which are, of course, are a big deal for Medicare. We expect that what's going to happen under these new models is that the volume of patients will increase. So we know there's a lot of stage 4, 5 patients in primary care practices across the country, but many of those patients are not being seen by a nephrologist, which is why we have a lot of patients still crashing onto dialysis. So the problem is, though, the nephrology workforce out there today is too small to be able to take care of all these new chronic kidney disease stage 4 or 5 patients. So nephrologists and practices know they have to involve other providers in the care of these patients to be able to make this work. So a little bit about these kidney care choices models. There's two basic models, the kidney care first option And then the comprehensive kidney care contracting graduated option all the way to the global option. Those last three are similar in terms of who they engage. So I'm going to concentrate on the kidney care first. The participants in that model could only be nephrologists and nephrology practices. So they couldn't involve dialysis providers or transplant centers. So it's just nephrology practices. And they receive payments for effective management. There's no risk sharing in the kidney care first option model. The other three models are open it up to more riders being involved, a nephrologist, they can bring in transplant providers, transplant surgeons, they could have gone in with a dialysis provider. So those models have more kidney related people involved. In either of these sets of models, other people can be brought in, like pharmacists and dietitians and others, to help care for these patients. But the people on the right-hand side are the core pieces of this model, and then they can make the decision who else they bring in. You can see in the graduated to the professional, so the global option, basically these are risk sharing models. And so as you go up from the graduated to professional to the global option, it's just a greater share of the cost sharing and risk sharing. So the global option, the practice takes on 100% of the total cost of care for Part A and Part B services. Doesn't include Part B. So how do they do this, and how does this payment structure work? Well, in the kidney care first option, and indeed the other models as well, it is based on a CKD quarterly capitated payment. So for each chronic kidney disease patient that they take on, that gives them about $1,000 over the year. So it adds up to about $1,000. The adjusted monthly capitation payment for dialysis patient is about $3,400 a year. The kidney care first option also has a performance-based adjustment. So basically on the metrics that I was just telling you about, all the practices are lined up, and then they look to see if they're doing better than average practice or worse than the better practice. So if they do better, they get a reward. If they do worse, of course, they can suffer a financial penalty. And then all the models have a kidney transplant bonus, so that $15,000 to keep the patient healthy with a healthy transplant for 3 years. And then in the last three models, there's also that shared savings, shared losses. So basically, again, just kind of emphasizing what I've talked about before, they're going from a fee-for-service payment, which is typical in this area with both chronic kidney disease as well as dialysis, and going to capitated payments. There's shared savings and shared losses in the last three models, and there's a variable risk reward based on the model option. The transplant bonus, it's just a little bit more about that. Basically, it's paid out in 3 incremental payments over 3 years. So you get the final $15,000 or the total $15,000 after 3 years if the patient still has a healthy transplant. And then there's a performance-based adjustment I told you about, using those metrics, and then the amounts that the practices get approximately for each patient. Dialysis, it's a little variable. It depends on how many visits the nephrologist or the advanced nephrology nurse practitioner does on the patient each month. So something that's really important, that besides those value-based pieces that I've just talked about, there's some enhanced benefits that I think where pharmacists can actually take advantage of. And one is the kidney disease education enhancement. Currently, the kidney disease education benefit is currently only available for CKD4, and now they're going to be transitioning both to CKD4 and 5 patients, as well as through the first few months of dialysis. And so it's been a relatively few number of practitioners that could do this. It could be a physician and a nurse practitioner or a nurse specialist that could do this. And it was largely, the uptake of this has been really low because they could make more money on just doing a regular evaluation and management visit. But what this does is allow to expansion to the patients that I talked about, so more patients, but any qualified clinician can provide this, and that includes pharmacists with an NPI. The billing codes are those that I just showed you here. And if you look at the mean payment, if just in one state, I Googled this, the mean payment for an individual visit is about $106, roughly in that region, and the group visit about $21. And interestingly, on the group visit, it doesn't just have to be Medicare patients. You could include in your group Medicare and non-Medicare patients. It's not clear right now whether incident to billing is necessary for this for pharmacists. I'm working with CMMI right now to get that clarification. They've been so busy with just making adjustments on the major part of the risk sharing and some of the things about the models that they haven't been able to really focus in on these enhancements yet, but I expect to get that information soon. So topics can include medication review, hypertension management, anemia, cardiovascular management, and a lot more. So a lot of medication-related issues could be discussed using the kidney disease education benefit, and telehealth can be used to provide it. There's also a second enhancement, the post-discharge home visits. Currently, post-discharge home visits must provide it under the direct supervision of a physician and typically by the physician, and other qualified clinicians are not able to provide these visits. These new value-based models will allow preferred providers that act under the general supervision of the nephrologist to visit the patient. And CMS has verified that pharmacists could be a preferred provider. The physician doesn't need to be present. It will be incident to nephrologist services billing, and there are up to 9 post-discharge visits within 90 days following discharge. These, I think, are the coding that will be used. So it's based on number of minutes for the evaluation. And I am just waiting to have these confirmed by CMS. These are the same codes that are used in other value-based models of care that CMS has derived. So I believe these will be the codes. And then telehealth, they've expanded the telehealth benefit. Used to be really limited to real-time communication between patient and clinicians. I still believe that's the best way to do it, but they're also allowing asynchronous store and forward technology to share information with other providers, you know, that are working with patients, and that could include pharmacists. So it will also allow home dialysis patients to have their clinical assessments done via telehealth, which is a way and a mechanism that I believe that we can get into patients' home, and working with those patients at home is the best place to do it. And truly, even working with in-center dialysis patients, it's better to do it in their home because then they have their medications accessible, and dialysis reduces cognitive function. So it's really better to talk to the patients at home rather than during their dialysis session anyway. So just to kind of recap, these new models allow for other providers, including pharmacists, to be involved. And I think this is our time. We've got to take this opportunity and move forward before these practices find their other partners and get other partners involved, you know, pushing a pharmacist out. And including a pharmacist on the team will allow nephrology practitioners to care for more patients. These are the performance-based components that I think require optimizing medication management and just focusing on some of the things. The highest percentage of hospitalizations in patients with chronic kidney disease and dialysis are cardiovascular hospitalizations and infectious hospitalizations. So decreasing those two types of hospitalizations are key to reducing hospitalization costs. So for pharmacists and ambulatory pharmacists, that means optimizing things like blood pressure, diabetes, heart failure, dyslipidemia, potentially anemia, as well as perhaps good antibiotic use or reasonable antibiotic use and catching infections early. And then I wanted to mention that in the future, there's going to be a chronic kidney disease progression metric. I'm on the CMS technical extra panel for this. And why this is important to pharmacists is this is where I think that because diabetes and hypertension are the two largest causes of end-stage renal disease, focusing on diabetes and hypertension management and using those medications that we now know reduce kidney disease progression, so ACE inhibitors and ARBs, you'd be astounded at how infrequently they're used in chronic kidney disease patients, as well as our new SGLT2 inhibitors and GLP-1s, which both have been shown, especially the SGLT2s, have been phenomenal in terms of course, reducing cardiovascular endpoints as well as kidney endpoints.
Wendy, we have a question from the chat.
Sure.
The question is, our nephrologists are asking for AmCare pharmacists to help with the education and monitoring for CKD3A and B patients who will be starting SGLT2 inhibitors. Can we use the billing code CPT G0420 for that?
Cannot. So these are limited. So the kidney disease education credits right now are specifically for stage 4 and stage 5 patients. I know that's killing you because I agree that we need to even go further upstream because really we don't want to get patients even getting to stage 4 chronic kidney disease. We're going to have them have kidney disease. We want to keep them at stage 3 or 3B. But right now, these models are focused on CKD stage 4 and 5 non-dialysis. And, you know, I think that the fact is, you know, CMS needs to get their hands wet, you know, with these new models. And if successful, I believe they will probably go upstream, and I'm hopeful that they will, but that's not the case right now. It's not to say that you can't see these patients, but you don't have the same benefits that you can take advantage of in terms of payments. So recognizing that fact, a core group of FCCP nephrology PRN members got together back in March. We educated about 35 of us on these new models of care using, you know, some policy experts at the National Kidney Foundation, as well as a policy physician nephrologist at UCSF. And we were convinced with what they said that this is a huge opportunity for pharmacists, and we cannot just sit around and do nothing and wait for somebody to ask us. So a core group of that 35, so probably more 10-ish or so of us, worked on creating an initiative to advance American kidney health through optimal medication management. And our vision is that every patient with kidney disease receives optimal medication management through team-based care, including a pharmacist, to make sure their medications are safe, effective, and convenient for them to use. And our mission is therefore to engage pharmacists. That's what I'm doing today to talk to you about. I've been engaging other pharmacy groups as well, but the stakeholder groups go so far beyond pharmacy. We've engaged, and I'll talk about some of the people that we've engaged, but it has to, of course, include physicians and patients and others. So we have a huge engagement initiative under this to create partnerships to move this whole thing forward. We, under our big umbrella of this initiative, we have 4 sub-initiatives that kind of are working hand in hand. The first one is developing pharmacy practice standards for optimal medication management in kidney disease. Interestingly, we don't have those in the US. Our Canadian colleagues do, and I'll show you in a moment. We've got a couple of people, pharmacists, one from Canada that's working with us to develop those pharmacy practice standards. Going kind of parallel to this is a group on developing pharmacy education standards and curriculum. So recognizing that we may need to even get pharmacy technicians involved, they're going to be evaluating what do we need to bring pharmacists at various levels and pharmacy technicians up to speed in the kidney disease area to really focus in on some of the nuanced things that we need people, you know, that everybody that if we're creating a standard of practice, how do we educate them to that standard of practice? Importantly, we have a roadmap group. This is basically the group that's going to get together and figure out, how do we do this? How can we take practices that are already out there and use what they're doing and learn from them to be able to create roadmaps for different implementation of these models in various parts of the country, where some areas of the country, we have lots of ambulatory care pharmacists and health systems far and wide, like we do in Minnesota, where we can get, basically get those pharmacists involved in this, and areas that we don't, that we need to think about, different areas of the country and different practices where we can integrate pharmacists and how we can do that. And that's what that roadmap group is doing. And then the fourth initiative is an engagement piece, and engaging the key stakeholders. So here are the initiative leaders. I'm one of the initiative leaders, along with one of my good colleagues, Rebecca Maxim from Auburn University. And then the sub-initiatives, you can see the different leaders. So we've got Katie Cordone, Marissa Battistella. Marissa's from Canada. She's going to be helping us move us, towards developing those practice standards. We've got the nephrology education standard groups, Joanna Hudson and Calvin Meany. Calvin just gave a presentation at the latest ACCP meeting on this initiative. The kidney care model roadmap, we've got Dr. Harold Manley, who's one of my good colleagues. He works with Dialysis Clinic Incorporated and just had a really significant publication in the American Journal of Kidney Disease on the reduction of hospitalization with basically a multidisciplinary MTM program. And then Dan Weiner, who is he's an activist nephrologist. He's very in favor of having pharmacists, and he's other co-leader of this group. And then the engagement piece, this is why I'm talking to you today. I'm one of the leaders of the engagement initiatives, sub-initiatives, along with my good colleague, Amy Parton-Pye. Who have we engaged so far? Basically, we started right with the ACCP nephrology PRN, and now we're outreaching to the ambulatory care PRN. We'll probably be making a similar presentation to internal medicine PRN, and maybe some of the other subspecialties or critical care and others as well. We've engaged the Get the Medication Right group. Their initiative, which is nationwide and really focuses in on broadly all of pharmacy, CMM across all kinds of disease states and things. We realize we have synergistic goals, and so I'm going to be sitting in on one of their work groups, and we're inviting one of the GTRX leaders to be part of our work group as well. We've also engaged the Community Pharmacy Enhanced Services Networks. There's some areas of the country where we have independent pharmacies that do enhanced services of hypertension, diabetes management. So they are part of our roadmap group. We have engaged CMS. So Tom Duval, who is one of the architects of this model, and I are in communication, and he has agreed to be a consultant with our group. He believes that pharmacists would do really well in terms of these new models. And so hopefully we'll have CMS on our side as well. The Renal Physician Association, this is the group that advocates for nephrologists and advanced nephrology nurse practitioners and physician assistants that work in the nephrology space. We have got them on board. They are gung-ho about this. And in fact, one of their RPA members are a member of our roadmap work group. So that has been significant because we know we need physician support, and the RPA is in constant contact with CMS. And so it's really important to have them engaged as an organization. I'm also consulting with one of the large dialysis providers as they're thinking about how that they want to optimize their medication management in dialysis patients. We've got the National Kidney Foundation on board, both with their CMO, and we have a policy expert from the NKF that is in our engagement work group. And then we know we need to engage patients. They, of course, are our most important customer here and most important stakeholder. So I've engaged the American Association of Kidney Patients. It's the largest advocacy body for kidney patients across the US. I've got the past president on our engagement work group, and he is just gung-ho to move this forward. And he's given me a couple opportunities already to get out in front of that group of patients. So it's been phenomenal. And then we've got a number of local things going on as well. So within our College of Pharmacy, I'm hoping one of my colleagues, Jean Moon, and I see she's on, will give a little shout out on what she's doing here with one of our local nephrology practices, and working with our Whole Health Systems Alliance for Integrated Medication Management, which is a group of basically an administrative pharmacist who supervise medication therapy management, or CMM, programs across the state of Minnesota, and 15 health systems engaged. So it's really important. We're really moving quickly, and it's just been just an amazing response. We've got no negative input on this as well. It's always all been positive. So what are our next steps? Basically, and I'm going to let Jean speak to this, we need you to engage your local nephrologist or nephrology practices to determine if they've applied to one of these voluntary models and been accepted by CMI to go forward. And so that's step one, to know if anybody in your area or anybody that you work with as an ambulatory care pharmacist has engaged in these new models. And then if you find out that they have that discussion of pharmacy enhancement of their nephrology services through comprehensive medication management. When you're talking to nephrologists, you should be focusing on cardiovascular management like diabetes, hypertension, heart failure, dyslipidemia, and talking about our new medications and how that requires really, I think really good monitoring of these new medications, because they're tricky. You've got diuretics, you've got SGLT2 inhibitors, you have ACE inhibitors, ARBs, especially the ACE ARBs can potentially tip the bullet and actually can tip patients into acute kidney injury. SGLT2s, of course, promote a diuresis. You have to be careful with the balance of diuretics and SGLT2. So I think they require some unique monitoring that I think we do best. And then you should be utilizing that kidney disease education and post-discharge home visits, those enhancements to those models that we can actually bill for, or have the nephrology practice bill for us and get reimbursed for it. And then lastly, get involved in the AAKH through Optimal Medication Management Initiative. We have 4 work groups. Those 4 work groups already have members, but as we find out, and we'll be developing probably subgroups to get various tasks done in these, we'll need and certainly need more work group members. We'll also need consultants, particularly as we go forward with the roadmap group, as well as practice standards and the education pieces. We'll need feedback to make sure if what we're proposing makes sense to ambulatory care pharmacists. And so if you want to get involved, then you need to contact me or one of the other people on this phone, like Anne or Ela or Chrystian or Jean Moon, and we can help you get involved. That is really the end of my presentation. So I wanted to make sure that there was enough time for questions, and I know that you guys have been monitoring the chat box. Have there been any questions that have come in?
Just that one that I mentioned. I don't see any others right now.
Okay, well, Jean, I want you to talk about what you've been doing at the local level here in Minneapolis to engage one of our groups, our nephrology groups.
Yeah, and I want to say that we're still probably in the beginning stages, but it's been pretty exciting so far. So just based on our patients at my clinic, we reached out to our local nephrology team who manages most of the patients in our system, and made some connections, and it was great. Wendy was available to be at those meetings as well and explain kind of where these initiatives are heading, and we got to learn a little bit about what this local group has been doing. And I think they're still figuring out what they're doing as well, as they received notification that they were in the studies. But I think we've engaged in some good conversations about how pharmacy could contribute. I think it was really nice to hear that the nephrologist definitely felt that pharmacists could contribute. Currently, they're utilizing nurse practitioners for some of their TCM care. So we were told that every patient that of theirs on their panel that is hospitalized, they have to do a TCM visit with them and have some paperwork to document within 24 hours. And currently their nurse practitioners are doing this work, and the nephrologist definitely felt like pharmacy would be a better fit for this role. So we're really trying to explore how this would work. What would that reimbursement look like? What kind of volume are we talking about? And so we're pretty excited, but yeah, definitely at the beginning stages. And really it just started with Wendy teaching me about what was happening, and then me reaching out to one of the nephrologists I work with.
Thanks, Jean.
There's another question in the chat. It says, Jean, will you or your clinic be the pharmacist contributing, or how are you planning to get pharmacist involvement with the local group?
Yeah, so I think some of those details are still getting worked out. So our nephrology team, they actually manage quite a few of the health systems in the metro area. And in our discussions, we wanted to target somewhat which systems we would be piloting some of this work with. And he had identified one of the health systems that actually I'm a part of with North Memorial. And so we engaged that group of practitioners. So there would be about 6 pharmacists in total at this point, but we're starting to look at capacity. So we wanted to understand what is this volume and patient panel that we would be expected to work or see on our end, and we're trying to see if that is feasible or not. So it would be a group of pharmacists. And we're just not exactly sure, again, how that system would work.
There's another question in the chat, and this is probably more for Wendy. Our nephrologists are also asking for AmCare pharmacists to manage patients on EPO. Can we use any of the referenced billing codes for that type of work?
Right now, there are no specific codes for anemia management. That's something under a new value-based model of care, understanding that anemia has been associated with higher rates of hospitalization and higher healthcare costs, that treating anemia is really an important component. So as you know, probably you know, there across the country, there are a few pharmacy managed anemia clinics in the VA. We had one at the University of Minnesota, and know there's others. But within these new value-based models of care, the whole conversation needs to be around for anemia is reducing, potentially hospitalizations and better quality of life for the patients. So managing their anemia, which we know, and let me just say, since the ESAs had been demonstrated in 4 trials to increase cardiovascular outcomes in a bad way, that, the use of ESAs in stage 4 and 5 patients have just plummeted. And so a lot of these patients are being undertreated for their anemia. As you probably know, we have new HIF-PH inhibitors, so hypoxia-inducible factor prolohydroxylase inhibitors. I can't say that 3 times fast, but they will be, roxadustat will be coming on the market, I think, next year. They completed their phase 3 clinical trials, and it will offer a new opportunity to treat anemia, especially in stage 4 and 5 patients when they're not coming into a dialysis center where they can receive their ESA injections. So again, it's under this whole value-based piece. You can't really use, it's possible though, although let me just back up, okay? Because that kidney disease education credit, at least in the enhancement, I should say, would allow you to bill for anemia consultation, anemia management services. So talking and educating the patient on anemia, talking about their medications and things. So let me step back. There is not a specific way to bill for ESAs and such, but you could use the kidney disease education enhancement to bill for that.
And the follow-up question, it's asking about, and I think those the new medications you were talking about, it says, are those self-injectables or clinic administered?
I'm not sure. Are you talking about the SGLT2 inhibitors or are you talking about the ESAs? The HIF inhibitors are oral. The HIF pH.
That you said that you couldn't pronounce or say, or that you said couldn't say 3 times fast, those investigational agents. I think that maybe she's asking about that.
The HIF pH inhibitors. I'm not going to say it again, it takes too long, but those are orally administered. And they're typically administered, 3 of them are on daily schedules, and roxadustat is 3 times a week, which is a tough one for patients to do if they're not on dialysis and getting it administered in the dialysis center.
So I have a question maybe that would be of use to the group as well. I have 2 questions. The first one is, for these codes, this would start April of 2021, is that right? So it's not something that can be used right now.
Correct. I mean, you can use those codes, I think, but the financial, actually, I think those codes can be used. The financial pieces, and I think when I think of the financial pieces is the penalty and rewards parts of this will be instituted. So the counting and where CMS will start looking at the financial pieces start in April 2021. It's possible they might even push that back further as they get feedback from nephrology practices. But right now, you can play in the sandbox. Those codes are billable for the enhanced services. It's just that the profit, the risk and reward parts of that pieces of the model don't come into play until April 2021.
Okay. And then follow up to that is the KDE, the kidney disease education benefit, where you can bill that code. Is that just education or is it management? Because that's something that right now I think we all struggle with in our practice is we could manage the hypertension from the primary care end, but when the nephrologist is making adjustments on the medication and for their hypertension, for example, and then we are as well, that just muddies the water and it gets confusing. So is it strictly meant for education or is it also management and adjusting medications?
You know, that's a really good question. When CMS has put out their, basically their information about this, it just gives a wide variety of topics that can be covered. So technically it doesn't say management, but they said the topics can be varied and actually it can be used for even more beyond the topics that they have indicated. I think they're going to be a little bit more, shouldn't say lax, that's not a good word. They just said it's opened up the opportunities for more topics. Now they haven't said that includes medication management, but that's something that actually I'm going to jot down and ask Tom about to see if we could use the kidney disease education enhancement to provide medication management. I mean, the education and the medication management to me go hand in hand. And since they're opening up the topics that can be discussed within that, it may be that medication management piece could be included. So what I can say is I can ask about that and inquire and see what they say.
And then there's another question in the chat. It says, are the education billing codes able to be utilized in a primary care clinic setting, I assume like versus a nephrology practice, or is there a requirement to have that service provided in a nephrology clinic? Certainly connecting patients with CKD stage 4 and 5 should be referred to nephrology, but can the codes be used for early education?
I think the answer is that it needs to be within the practice of a nephrologist or a nephrology practice. Right now, again, these are things that are kind of gray areas, right? Because they've expanded the use of this, they've expanded the patients, but these new value-based models of care at its very core include nephrologists and the nephrology panels, you know, the patients that those nephrologists see. And the wording's kind of vague, but you need to probably be in the practice with a nephrologist to be able to build those codes. It's not clear whether the CDE needs to be billed incident to a physician services. I'm trying to get information on that as well. But when they would say incident to a physician services, it would be the nephrologist services. Really good question. Well, we are just a couple minutes over our time, and I know all your time is valuable. I'd be happy to stay online for a few minutes longer if there's other burning questions out there. I'm going to terminate, I think, I guess I can keep the recording up if there's other questions that need to be answered. But thank you so much for all of you for listening to this presentation, and please make sure you reach out to me or one of my other colleagues if you have questions or would like to get involved in this initiative.
Wendy, it looks like there's a couple of questions in the chat.
All right, can you tell me what they are? I guess I can get into.
And Ela, I don't want to steal that from you. I just didn't know.
I got kicked out.
Oh,
Shoot.
To piggyback on that question, what if that patient is being followed in a diabetes specialty clinic and the nephrologist entered a consult or added a question to consider the addition of an SGLT2 inhibitor?
That I think that if the nephrologist referred to the pharmacist, I think that should be allowed as long as there is a referral to the pharmacist from the nephrologist. That's also a good question. My answer would be, tentatively, yes, I think so.
And then another question is, what if you practice within the same healthcare system, but are physically located away from the nephrologist, but cannot communicate with them?
Well, I'm thinking this is where the telehealth technology comes in, right? It's really an important piece. You do have to be able to be in contact with the nephrologist to be part of this nephrology, team. And so I'm hoping that we can all use telehealth technologies to be able to do that.
And there was a clarification, can communicate with them, just not but not physically located in the same place.
Yeah, I believe that as long as you have a physician referral, I don't think you're going to have to be in the same building. And if we can use telehealth technology, there's no reason why people should be in the same building anymore. Of course, you never know what CMS will do in their infinite wisdom. Sometimes they can be sticklers, but especially now that COVID-19 has opened up the telehealth avenue so much, I just can't see them completely going back. So I'm hoping that we're going to be able to provide a lot of this care through telehealth communications.
Yeah. Hey, Wendy, I had a question. I really like the CK or the kidney disease educator, but just to be clear, there's no certification that needs to go along with being able to provide that education at this point. It's not like diabetes, certified diabetes educator. Right now, it's just it's a theme for these patients that qualify.
Yep, there's no certification that's necessary. Good question.
And Ashley's asking where we can go for more information or resources.
Okay, so for more resources and information, you can get back to me and I can refer you to, specific websites if you want to learn more about the models and those sorts of things. We will and are putting together a website for our initiative, and that should be up shortly. And basically what it will do is we'll put those kind of resources on, as well as each one of our work groups and our work group progress, so everybody can keep apprised of that. So when that website is up and running, I will send a message out to the entire ambulatory care PRN to let you know that that's happened. I see a lot more people still hanging on. Are there any further questions?
It does look like there was a comment about in the VA system, they work closely together with nephrology, but the referral isn't always official. We communicate within the electronic notes or addendum. So I think there's a question or maybe comment if that's okay, if that is an okay model.
I think, yeah, oh, certainly. Yeah. I think the VA system is an integrated model. It's like a Geisinger, a Mayo, and all those that they have all those touch points and an integrated system. Yeah.
I would say though, in our healthcare system, the incident 2 rules have gotten a lot more strict about having like a formal description, like we need that service, and kind of making sure that we're documenting that correctly. So
Yeah,
I
those
don't know, I think
things.
maybe a referral is not needed, but some kind of communication would help.
I'm jotting that down, Chrystian, and how does the referral need to be done if there's any specifics? And that's another good question for CMS.
Yeah, even if they're in the provider's documentation, if it's documented, like that would be enough too, just as long as you knew where to refer, where to find that. It has to be documented.
I have another question, and that is there a way that pharmacists working in separate primary care practices, not in a nephrology practice, can they partner with these nephrology practices to meet their value-based payment? You mentioned this at first. There's these new payment models if they meet certain criteria where they get paid for each patient and that sort of thing. So how can pharmacists not in their practices help with that? And then also, I guess, receive any, like, how are they compensated for that? If the, if the physicians in the nephrology practices are referring these patients to pharmacists outside of their practice to help them meet their goals. Do you have any
good question? I think Jean is thinking about that in terms of working with the nephrology group that she's working with. So we think it's going to be a combination of things that we can bill. It's unclear if, for instance, we can directly bill the CDE, the kidney disease education, or if we need to do incident to a nephrology practice. But what I see is basically flow through, they get, if it's incident 2 and they're getting the payment back to their practice, then there'd be a flow through to the pharmacy for that piece of it. I also think that we have to develop a value-based, basically the value proposition for the pharmacist. So thinking about having a panel of X number of CKD stage 4 or 5 patients, transplant dialysis patients, how much should a pharmacist be given as part of the capitated amount that comes into the nephrology practice for each one of those patients? How much should a pharmacist get for providing comprehensive medication management for those patients? And so that's something that the roadmap model group that, is one of the things that they need to think about. How can we put that forward? How much should we charge as part of that capitated rate to see those patients, and doing it in a comprehensive way? So that's something we have to work out, but that's part of one of the goals for the roadmap group. But we have people working it out right now. I just talked to a nephrologist that I'm going to be speaking to further on the phone in a couple of weeks, but he's in one of these models, and I don't know which one, but he has already hired one pharmacist, is now hired a second pharmacist, and we're getting on the phone in 2 weeks, and I'm going to find out how he's making that happen. And that's the kind of information, as we get that kind of information, we're going to be sharing on our website.
Yeah, and Norango makes a nice comment. I was just saying, like, this sounds like RVUs, but yeah, it's basically finding the weight of our value and how we. And I want to know how to get to that $15,000 bonus at the end too. That would be.
Well, nobody brought that up today, but of course there are transplant pharmacists. So every transplant center, there has to be somebody with pharmacology expertise to work in the transplant center. Most transplant centers utilize pharmacists, trained transplant pharmacists to do that. However, the care provided by those transplant pharmacists varies hugely across these different transplant centers. Some pharmacists only see patients while they're in the hospital. Others only see patients when they're in ambulatories, and maybe for only the first year after their transplant. So when we're talking about these standards in practice, we really do need to think about that whole care frame from not only just hospitalization, but now through the first 3 years of that transplant to make sure they're being monitored very carefully with their transplant immunosuppressants. And that oftentimes pharmacists are the ones that would be watching those levels and things. So it's a really big opportunity even for expansion in the transplant area, because again, there's just such a wide variety of practice. We don't have a standard of practice out there today. Anybody else? Well, Jean and Ela, Chrystian, and Anne's not on here anymore. Thank you so much for helping out today.
Thank you for that excellent presentation.
I just want to thank everybody who's still online for being here, and just look for further information as we get some updates here. Thank you.